Okay, welcome to Of Ballet and Barbells, my case presentation about an extension-biased athlete with extension-based low back pain. My objectives today are that you will be able to identify at least 3 risk factors for spondy in athletes who have low back pains in order to know when it's appropriate to refer for imaging, things like that. And also that you will be able to describe 2 methods to progress the standard core stabilization activities toward the more functional stability that's required for a return to sport. I also want to discuss why that progression is not just important, but really imperative. So, overview of the patient I treated at Engineered Sports Therapy in Everett. She had extension-based low back pain. You can see on the slide the body functions and structures that were affected and her impairments. She had pain with lumbar extension, especially holding that against gravity. So anything involving overhead reaching, stuff like that. She had poor core and glute strength and endurance. The muscles fired, but they just weren't able to stay strong for long enough to do the things that she was asking of her body. Activities and participation, dance, CrossFit, gymnastics. So in dance, not being able to do lumbar extension, that's a lot of movements in dance. And she was just marking all of these movements in classes. In CrossFit, she couldn't do deadlifts, cleans, kettlebell swings, anything overhead. She was, interestingly enough, subbing things like planks and other core work in class, but it didn't seem to be helping change things much, and I'll talk about why I think that might have been in a little bit. Gymnastics, she had to give up because of her low back pain. This pain had persisted for about 2 years at this point, so she had given up gymnastics, but it didn't make her back pain go away. Environmental factors. Well, her chosen sports are kind of problematic here, right? Dance and CrossFit both put extreme stress on the low back. Low back pain is among the most common diagnoses in dancers, regardless of their age or what style of dance they study. And in CrossFit, well, aside from the bad rep that CrossFit gets in general among PTs because of the poor instruction that's out there, the CrossFit organization itself has recommendations about how to handle youth. They recommend a special teens class for kids ages 12 to 18 in order specifically to ensure that they have safe and developmentally appropriate training modifications. They offer a CrossFit Kids certification that has really detailed and evidence-based information on how to accomplish these developmentally appropriate training modifications. But this patient didn't have access to that. She was just in with the adults. Now, some CrossFit coaches are really very knowledgeable and they can accommodate youth developmental needs, even in mixed groups. Others, not too much. And my suspicion is, of course, that the trainers she had access to were more in the not so much category, unfortunately. Her activity level was an issue. She was doing some sort of workout at least 5 days a week, sometimes 2 in a day. So like she'd go to ballet class and then she'd go to a CrossFit workout. Then she was adding PT twice a week. And then at the beginning of March, she went out for the school track team too. She was asking a lot of her body every single day. Another environmental factor for her was her mom was making her appointments on back-to-back days a bunch of times. We all know that's less than ideal for PT progress. It may have been unavoidable because she did have 2 other kids to deal with, but still less than ideal. Personal factors, her age is a factor because she's in her peak growth years. And adolescents are at higher risk for spondies in general. We'll talk more about why that is in a little bit. She's in 8th grade. She attends junior high. She's really smart. She's taking geometry already. Holy cats. One thing I found very interesting about her personally was she had gone vegetarian at some point in the last couple of years. So knowing how teenagers eat, that put her at an increased risk for nutritional deficiencies, which could affect bone density and neuromuscular development, especially when you're talking about someone who's doing such intense training. primary medical diagnosis was low back pain, specifically extension-based low back pain. She did have some previous imaging done in 2017. That didn't show a spondy, but her symptoms really kind of pointed that direction. So let's talk about risk factors for spondies for a second. The top one is age. Adolescents are at a much higher risk of spondylolisthesis because ossification of the spine goes anterior to posterior. And the pars interarticularis may not actually be fully ossified until age 25. So adolescents are at a big high risk there. When you add participating in extension biased sports, so we're talking gymnastics, dance, figure skating, football even, especially linesmen when they're coming off the line and crashing into each other. Also throwers, baseball, softball. There's a whole lot of evidence, a whole lot of research out there about cricket fast bowlers and extension-based lumbar injuries, which I think it's interesting, just the amount of evidence out there about that, something very specific. High intensity training, especially when we're talking about training more than 20 to 24 hours a week, because then you're frequently going to be training in a fatigued state. And there's also evidence that young women who are overtraining to the point of menstrual dysfunction are at even higher risk, because then you're messing with the hormones that are required for things like bone density. So then you've got maybe a gymnast with osteopenia. Let's talk about a recipe for disaster, huh? Other risk factors, excessive lordosis or anterior pelvic tilt, especially with abdominal and glute weakness, hypermobility, especially of the lumbar spine. I want to talk a second about how hypermobility can self-select people for extension biased sports. If you're really limber in your low back and you go try ballet, you might be really good at it to start with. And so that's going to encourage you to go to higher levels, which increases your risk of injury, et cetera, et cetera. So that the hypermobility, it's just kind of a feed forward mechanism, I guess. The other big key is prior medical history of a trauma or any kind of repetitive trauma. So car crashes, falls out of trees, and participating in things like gymnastics or dance that might give you repetitive trauma. So patient history, her lumbar pain started after a car accident in the fall of 2017. Imaging at that time was unremarkable. According to her mother, I don't believe any more imaging was done when she was referred to PT this January. My understanding was the doctor intended to order an MRI after her follow-up in late March if she was still having pain. She had painful lumbar extension. It was relieved with flexion and rest. She didn't have any other medical history to affect treatment. So, physical therapy diagnosis was just low back pain. I might have added more because in her assessment, the PT noted that low back pain was secondary to motor control deficits and decreased core and glute strength. This patient had a really hard time not going into lumbar lordosis first with just about every movement. She couldn't control it. It affected her functional movement. So motor control deficit, right? PT suggested twice a week, 8 weeks to start. That was in line with what the doctor also recommended. Patient and family goals, she just didn't want to hurt all the time. She wanted to get back to being able to fully participate in her dance classes and CrossFit classes without having to modify everything and without having it hurt. Physical therapy goals, they were pretty standard. Independence with HEP, increasing her knowledge of self-management skills so that she'd be able to address any recurrence of symptoms in the future. Full range of motion, full hip and lower extremity strength, being able to do lifting activities that required squatting and lunging. That's kind of sport specific for her. Increasing her core strength, improving motor control firing patterns, which would promote better stabilization of her lumbar spine with functional activity. This clinic, I really liked how they did very specific and measurable goals. So this last one, I'm going to read it. To tolerate 3 continuous minutes of diagonal lifts and chops between hip and shoulder height with a 6 to 8 pound medicine ball. So that's very specific. It's also a really good measure of functional stability. So I really appreciated those kinds of goals at this clinic. I thought it was neat. And of course, ultimately, we wanted her to be able to return to sport, meaning able to do all her sport-specific activities without pain or dysfunction. Interventions, we did transverse abdominis and multifidi activation and stabilization activities. We progressed those into more sport-specific mechanics, and we also did functional myofascial decompression. We all know the typical supine progression for transverse abdominis activation. I will say it's good to review the basics. This clinic, their population being higher level athletes, I found that the clinicians often kind of skipped over some of the basics. A lot of their patients didn't really need it. This patient, however, did. I found, like on her second or third visit, she was just not really getting how to activate her deep core, and she was subbing global stabilizers like erectus abdominis in, stuff like dead bugs and whatnot. I spent just a couple of minutes instructing her in supine transverse abdominis activation with self-palpation. I sent it home with her. I told her, progress this, work on it in, lying in bed, sitting up, standing up, progress it to doing, lots of things with it. I reinforced it with all our exercises in the clinic. She mastered it pretty quick. Like she got it, like an athlete. She got the concept really quick in supine. She really struggled, however, with muscular endurance. And when those deep core muscles got tired, she would substitute rectus abdominis and stuff like that. And I think that right there is why the extra core work she was doing at CrossFit wasn't really helping. I think she was just reinforcing poor neuromuscular firing patterns. And I found that we really had to back off things like dead bugs and stuff. We had to really regress those for her first few weeks until she could do them without substituting. Building on that foundation of activation, we moved into sport-specific mechanics. She had a real hard time transitioning to standing, so I found that tactile cueing was really useful for her. I used a hockey stick because we didn't have dowels. We had a whole lot of hockey sticks, though. So, but the tactile cueing, we've all done this, teaching a hip hinge with a dowel. And look, here it is. Here's where I would demonstrate some of the progressions we used. I started with the typical hip hinge drill, but rather than the 3 points of contact we're all familiar with the stick, I added a fourth point for her, which was her hand holding onto the hockey stick, but also her hand against her low back. So she had such lordosis in just quiet standing that she needed to actively posteriorly tilt her pelvis just to find neutral. And so that hockey stick and that tactile cue of her hand against her back was really helpful in retraining her brain for what neutral should feel like. I also put a band around her hips to facilitate glute engagement. So here's a picture of a hip hinge with a band. We used the stick as well as the band. She had all the things. It was wonderful. My progression was we started with hip hinges, just getting the right things firing, keeping neutral spine with that. Then we progressed to squats and lunges. She had a really hard time returning from a forward lunge without extending her low back. So the hockey stick, again, was really, really helpful. The band is getting into some more sport-specific training. With a band, you can start working on adding speed and power, working toward that hip snap that's required for cleans and kettlebell swings, but the band slows you down. So you're doing it in a slow, controlled way, but you're teaching that movement before you add the speed and power. So pretty useful. Back to my original slideshow. So that's kind of where we were when my time was up. We were doing all the tactile cueing with the band and the stick, hip hinging, squatting, lunging. Her form was improving. We were starting to work on adding a little bit of that snap against the band with her hips. My plan was to progress once she didn't need that tactile cueing with the stick. by adding dumbbells, kettlebells, even eventually a barbell in slow and controlled movements. So deadlifts, squats, lunges. My overhead progression plan, by the time I left, we were still working on tactile cueing, so back pressed against the wall, just trying to get her hands up overhead. Without pain. Eventually, I would have added weight, pressing motions. And again, once you master the slow and controlled movements and you don't need the tactile cueing, and then you start adding speed and power, stuff like that. That was the plan. Functional myofascial decompression is the incorporation of functional movement with the traditional Chinese medicine technique of cupping. Evidence on this is still kind of so-so, but research continues and patients do report subjective relief. I think it's kind of interesting. So there. This picture is close to the cup placement that we did with this patient. We did bilateral lumbar extensors and low thoracic extensors, plus her PSIS and QLs. Bilaterally. By the way, if you've seen on the internet people using fire to create the suction in cupping, that's totally a Chinese medicine thing. Nobody does it in PT. We just use a hand pump to create the suction. So then for her functional movement, we had her do a child's pose, like kind of a series of it. So that's what this guy in the picture is doing. There's a whole process of how to do functional myofascial decompression that they teach in courses. I'm happy to share resources if people are interested, but I'm not going to talk about it in depth here. She did report some subjective relief and less tightness in her low back after cupping. However, we only ever did it after therapeutic exercise, so I don't know if it was actually affecting her functional mobility or not. It would have been neat to try it before Therex or mid-session to compare, compare her functional mobility before and after cupping, but I didn't get that chance, unfortunately. Home program, I told you earlier, I sent home the supine transverse abdominis activation with the self-palpation, instructions to progress. We also had her do a mini band series. So she'd put a band around above her knees and she'd do some supine and sideline clamshell type exercises. And then she'd stand up and do like some monster walk kind of things. So activating core and glutes together, just really integrating that movement against some resistance. Outcomes. So plank on forearms, the first day she came in, she could not hold a plank for even 10 seconds before she fell into lumbar lordosis. And 4 weeks later, she was able to hold for 45 seconds when I retested her before I started seeing that lumbar lordosis. Her modified oswestry, she was at 35% disability when she came in, and 4 weeks later, she was at 20. I would note that the last time I got to work with her on March 3rd, she still couldn't hold her arms overhead without pain in her low back, even when she was braced against the wall. So we were making progress, yes, but we weren't there yet. But I ran out of time to play. Take home points. See what I did there on that slide? Points. Okay. When do we suspect a spondy? So this is where I would ask the audience for what are the main risk factors for spondylolisthesis, spondylolysis. When should we be suspecting it and sending patients for further evaluation or imaging? And then I'd answer my own question. The big three are adolescents, of course, with extension-based low back pain. No radicular symptoms, it's beltline pain. But the key there, the key word in that first point is adolescence. Participation in extension bias sports, seriously, always suspect spondy in a gymnast. There is evidence out there that between 50 and 86% of gymnasts who have extension-based low back pain have a spondy. So just always suspect it in gymnasts. Also, the other big one is a demanding training schedule, especially when you get up above 20 to 24 hours a week. And do look for the female athlete triad with this kind of overtraining. If menstrual function is not normal, that's a big risk factor for all kinds of things, including spondies. Other reasons to suspect a spondy: excess lordosis, anterior pelvic tilt, hypermobility of the lumbar spine, and some kind of history of trauma or repetitive trauma. Second take-home point, progression is required. Standard core stabilization just isn't enough for higher level athletic function. We have got to progress our athletes toward functional stability appropriate to their sports. It's good to review the basics, especially with youth athletes. Youth, because they may not have the basics mastered, or maybe they did one day and now they don't because they've grown 6 inches. And, they are literally changing one day to the next. So it's really hard for their neuromuscular coordination to keep up with that kind of growth. And so they may need to relearn some of these basics sometimes. But do remember with athletes, they usually have pretty good body awareness compared to the general population. So spending too much time on the basics can be really discouraging to them. And therefore, progression is required. We have to progress them to applying the basics to their sport-specific movements. It's imperative from a physical standpoint to prevent re-injury. It's also imperative from a psychological standpoint. Second quiz time. Here's where I would ask the audience for ideas for progression toward maintenance of functional stability that's appropriate for higher level athletic performance. My big ideas here that I would look to hear from the audience are be sport specific. Where are they needing to be stable? In what positions? And how do we get there? Progression of load. Form has to come before load every single time. So you always start with just the movement before you start adding any weight. And then speed and power, you're going to develop that once the slow and controlled movements are mastered. Let's remember that speed and power are a form of load. So form before load, right? Slow and controlled movement before you add speed and power. If I wanted to talk about specifics, I used CrossFit specific movements for this patient because it's a good foundation, and for transferring to other sports like dance. Also, that was her sport. And here's where I would ask for questions, and I would pray I could answer them coherently. Maybe I might talk about some of the very specific things that I did for her progression. I don't know. And here's where I would say thank you for listening. These are my references that I referred to, and I would leave those on the screen for a little bit.